We're at the 7th conference on pathogenesis and treatment and prevention in Kuala Lumpur. And we're here with Linda-Gail Bekker, who is from the Desmond Tutu Center for HIV in Cape Town, South Africa. And you know, before we get started, you made a big sacrifice by coming here. The work you do brought you here, but it took you away from the clinic where you're having actually while you were doing your presentation, the president of our country was making a tour.
That's right. This is quite an auspicious week.
Yeah.
It's the 10th year of PEPFAR, the PEPFAR programs, and I think to honor that, President Obama took some time out of his otherwise quite political tour of South Africa to visit a health center that has benefited from PEPFAR. And we were very lucky to be chosen. This is the DTHC Foundation Youth Center, which is down in the very tip of Cape Town and serves a large, very poor community just outside Masiphumelele is the name of the venue. And our youth center has registered within it 2,000 young people between ages of 12 and 22. And they come along for creation, education, and very importantly, sexual and reproductive health services. So President Obama visited us here with Ambassador Gooseby, and we were able to thank the people of America for PEPFAR, which has made such a huge difference in my country.
Yes, Ambassador Gooseby took over from Mark Dyball through the process of the original project was set up by George Bush, the second George Bush. So, but anyway, this is that was enough excitement. But what you presented in the presentation today and also in the press conference was the idea of transitioning, a practical way of a process by which you can transition from adolescence through adolescence into adulthood, and through the clinics that made sense, where you're getting into treatment and you have to now take ownership of that treatment. Tell us how you position yourself on that.
Well, it's something that actually the HIV community needs to learn from other chronic diseases. So we, for some time now, insulin-dependent diabetics, children with cystic fibrosis are, instead of succumbing with their illness in childhood, are growing into adulthood. And so those disciplines have for quite a long time now been dealing with bringing children from pediatric services through adolescence and into adult services. And the notion there is that you go from quite a nurturing, passive environment with family and a lot of caregiving, making sure you're taking your pills and doing all the right thing, through a process of actually separating and becoming autonomous and eventually becoming a self-reliant adult pill taker or medicine taker or program adherer. And you need to do it on your own. And what we find in those chronic disease programs is, if that isn't done well, first of all, adolescents can be lost from the program, so fall through the cracks, as it were, or they can end up being less stable or less well controlled in terms of the adult services. Now, what has happened in HIV care that has taken us all somewhat by surprise is that the children who were infected perinatally from vertical to child transmission are now surviving into adulthood. They're growing up and they've grown into adolescence. They've come with quite a lot of baggage, because if you remember, not too long ago we had monotherapy and dual therapy and less than adequate therapy. And so they've been exposed to perhaps suboptimal kinds of therapy, although that's better now. So they bring a long history of being exposed to antiretrovirals. There are problems related to the fact that they are adolescent. You know, it's hard to get through adolescence without disease. And we need to get them safely into adulthood as adherent, functioning, self-reliant HIV-infected adults who are going to survive into long-term care. And today's plenary was really about introducing that, first of all, to adult caregivers as a concept, and then saying we should celebrate this, but we should also get organized. We need to have programs that make sure that we do that properly. And there are great resources out there, but I think we as an HIV treating community also need to get some disease-specific programs HIV specific programs to be sure that we take these adolescents into adulthood. And this problem applies to resource-rich countries as well as resource-poor countries.
Just in different numbers and percentages.
Absolutely. I mean, I think scale is huge. In terms of the legacy, the burden of disease, I think resource-rich countries actually have a bigger problem because they have had treatment for longer and more of their kids will have been exposed to less optimal treatment programs. We, I suppose, we being less resource country, started combination ART later. It meant we lost more children in the beginning, but the children who are in the program at the moment largely all started with combination antiretroviral triple therapy. So they're in some ways better off in that regard. But, the board, I think we are in a good position to take these adolescents into adulthood, but we need to deal with the psychosocial, the emotional, and the physical components of doing that. And that's the challenge we threw out this morning.
So we had talked earlier about the age group. I think it's just so the community, because a lot of us are HIV and didn't really deal with this transitional thing. But your age in the pediatric is up to...
Well, again, that will vary setting to setting, but generally, say, with the South African setting, pediatrics goes to 13. Adults sort of begin at 18, and there's this gap in between where we don't have adolescent health. Now, in North America, in many parts of certainly centers, there will be specialized adolescent care. But again, that's not well thought through in HIV medicine. So again, it's about raising awareness for this need to specifically address adolescent HIV needs.
The kids that are in school, they have a lot of other things going on, a lot of other activities.
They need clinics outside of school. They need a lot of support around emotional and cognitive delay. Disclosure issues are huge. So I'm discovering my sexuality, but I also need to disclose my HIV status. That's an enormous stress on a young person dealing with a lot of stress already. So helping adolescents deal with that, come through that. We need organized programs to do that.
Today it seems like that the people who are, the young folks who are entering adolescence, who may be treated well and could have done very well on treatment, are likely to not need to disclose if they, and that's a choice, I guess, on their part as far as to other classmates. Certainly,
and again, part of that that support for the adolescent is not to willy-nilly disclose to anybody. In our disclosure program, we very carefully think through who, why, and when. Those are three very important questions. Who am I going to disclose to? Why would I do that? And under what circumstances? And indeed, when? Because all of that is really important. It can be quite harmful to do it too quickly, to too many. On the other hand, we know disclosure and support is an important component of good care. But that in itself needs to be managed for a young person who's growing into their adolescence.
I think the more we deal with this exceptionalism, which is of course important because HIV is an unusual and exceptionally difficult disease to deal with, but we also try to, and I've said this for many years, exceptional versus normalizing. And so when you disclose, I guess it's a good idea, just as the way I think of it, is to really just don't make a big deal of it. Just say, this is another disease. Think of me as a person who just has another, and many times you have multiple diseases anyway.
That's right. And I liked what Steve Deek's opening plenary to this conference was around, this is a chronic disease. And that's exactly what we're dealing with. Just like somebody with cystic fibrosis has to deal with going through adolescence and into adulthood, somebody with insulin-dependent diabetes, somebody with a physical disability also needs to go through adolescence. Or indeed, maybe I have an emotional stressor. We as human beings have multiple things we have to deal with in order to get through daily life. And this is another one. And really equipping. So it is about getting the balance right. Not being so hands-off that they're lost and fall through the cracks, but being sufficiently hands-on to support them through the process without making it exceptional. And I think finding that balance is really key.
Do you think you'll have at some point maybe a handbook of sorts
Actually, there are some resources already that are encouraging. There's a great website called Got Transition that people can go to already, which is generic and for all diseases. Then the New York State Department has put out a very nice book on transition. And then the US Academy of Pediatrics just put out a consensus statement on transition. So there are and people can happily download my podcast today and get the plenary if they'd like to.
Can you define the how to get to that?
Well, if they go to IAS 2013, it won't be there immediately, but within a couple of days, and just search on my name, Linda-Gail Bekker, they'll be able to download. 2 Ks, B-E-K-K-E-R.
Great. Linda, I thank you so much for being here.
It's been very
pleasure. Charming, and you said you were going to be good on camera, and you were.
Thank you for having me. It's wonderful to be here. Thank you.
Thank you so much.
All right. Take care.